Our clinical view is about RH incompatibility and pregnancy. So here's the scenario that we're looking at. All right, so you have the mom, she's RH negative. And if we go back a couple slides here, if this thing will ever work, we saw when we're talking about RH blood types here, you'll notice if you're RH positive, you have the antigens. We've already established that, okay? If your blood type, if you're A, it means you have the A antigen or A surface antigen. If you're B, you have the B surface antigen. If you're AB, you have both, right? So if you are RH positive, you will have the surface antigen D present. If you're RH negative, then you'll have no surface antigen. But notice, RH positive folks don't have the antibodies, the anti-D antibodies. And then there's a little special note over here that says you will not have the anti-D antibodies in an RH negative person until you are exposed to somebody that is RH positive. Okay, so keep that in mind. The most common time when this occurs is during pregnancy. So going to our clinical view here, so we have our RH negative mom. She gets pregnant. First baby could also be RH negative. Nothing to worry about. Second baby could also be RH negative. So nothing to worry about. It's not until when mom is exposed to an RH positive baby, and because of that, now mom can produce the anti-D antibodies. So no problem right then, okay? But what happens is now for future pregnancies, there's a problem because one, antibodies can actually cross the placenta. Placenta is a very effective barrier. It prevents a lot of pathogens from crossing over from mom to baby. Doesn't stop everything. Antibodies are one of those things that may cross over. So if the baby, okay, is going to be RH positive, well, now you have the antibodies that can come over there and go after it. So we have to be careful with that. So if they cross the placenta, what are they going to do? They're going to go after the baby's red blood cells. Hemolytic anemia, right? Starts killing the baby's red blood cells. Baby needs those red blood cells to oxygenate those developing tissues. A lot of issues can happen. And if you look here, look at these symptoms. Anemia in capital, bold letter, not capital, but in bold letters here, hyperbilirubinemia, right? So what is that from? Where do you get all that bilirubin from? Yeah, it's the recycling process of red blood cells. We talked about it last period, where when red blood cells, they get broken down by the spleen and the liver, right? And especially when hemoglobin gets broken down, one of the intermediates is bilirubin. So you have these antibodies that are going after this child's red blood cells and busting them up and causing hemolysis, breaking them down. And so the baby gets an increased amount of bilirubin in their blood, hence hyperbilirubinemia. And then, of course, if you're anemic and you're having this going on with the destruction of your red blood cells, there's no surprise that there's heart failure because you can't oxygenate the heart tissue. And we're going to talk about that in lab today, about the metabolism of cardiac muscle tissue, right? And it'll make more sense to you a little bit. But if you don't have oxygen, you're going to get ischemic tissue. And in the heart, I mean, in every tissue, but especially in the heart because it works so hard, ischemia, bad, very bad. Right, and so how do we prevent that? We give mom a special medication. Does anyone know the name of that? Rogam. Has anyone heard of Rogam? So Rogam is going to be this special medicine, okay, that helps with the immunoglobulins. A lot of hospitals won't even wait until the mom has been exposed. A lot of times, first-time pregnancy, hospitals, they did it up in New York, you get a shot of Rogam just to be safe. Better to be safe than sorry. Won't hurt the mom, right? But that's usually what will happen. We'll give a special type of concoction serum. The most common one is called Rogam, and that's going to help mom, all right, with those antibodies there. Okay, so that's blood typing. Now let's talk about, that's red blood cells, right? So we're now going to talk about our white blood cells, and then we have platelets to discuss. So let's look at, and we'll get into more details on the leukocytes when we get into the immune chapter. We're just going to kind of give you a brief kind of broad overview here as we go through. All right. So you're all familiar with the purpose of our white blood cells here. They play the defense role, right? So a lot of times with our our white blood cells, they're going to be just minding their own business until they come across a pathogen. And we'll talk about that process when we get to the immune chapter. But white blood cells have one job, okay? They come across a pathogen to initiate the immune response, whether that be that specific cell itself or that cell goes and informs another white blood cell that there's a pathogen present. Neither here nor there, we're going to initiate the immune response. And so these cells do not carry respiratory gases, so they don't have hemoglobin in it. But guess what? They got tons of organelles that are going to make proteins, specifically enzymes, because we're going to need these enzymes to kill pathogens, right? So they're going to have tons of organelles. Now, two characteristics that are important that you know about these types of cells. One, they're motile, which means they can move around. Right? And two, they're flexible. They're flexible. That's important because these cells have to squeeze into places, all right, that might be difficult to get into. So they need to be flexible and they need to be mobile or motile. All right, so this last part here, and I've said this to you guys, I think to you, right, that cool. Most of our white blood cells are found in the tissues there. Right, not in the blood. You already know that. And I've said that several times to you folks, but just to review so I get it into your heads. Right, remember, when we centrifuge the blood, less than 1% of your blood is that buffy coat. And that's where the white blood cells and the platelets are. Right, so this very small percentage of your blood contains the white blood cells. So these two terms here that I want you to be familiar with, diapedesis and chemotaxis. Yeah, diapedesis is when some of these white blood cells, they could be in the blood, have to escape the blood. They got to get out of the capillaries and get into the tissue. All right, so that means they create a small gap between the squamous cells of like a capillary, for example, and they squeeze their way through. I'll show you some pictures on this. The other one is chemotaxis. Right? I think of chemotaxis like a signal flare. You shoot the signal flare up in the air, then people are alerted to where there's an issue or where someone needs to be rescued. Same thing here with our white blood cells. They need help finding where the infection is. So the cells that that are infected or damaged will release chemicals, and that's their version of the signal flare. And so those chemicals will attract the white blood cells to the area of distress. So the white blood cells then undergoing diapedesis will squeeze out of the blood vessel and go to the damaged tissue and fight pathogens there or help to clean up the mess. All right, but keep that in mind. Chemotaxis is very important. That's how we get our white blood cells to the infection site. All right, so let's talk about the different classes here of our leukocytes. You can see here on our screen, you have granulocytes and agranulocytes. And I briefly talked about this before. Granulocytes are any cell that have the last four letters or five letters as PHILS, phils. Okay, neutrophils, eosinophils, basophils. Right, so granulocytes, we describe them because they have, when we stain them with our dyes for a light microscope, you can see the granules, all right, are staining, all right, quite significantly, very distinct. The other class of leukocytes are going to be the agranulocytes. And so even though they have granules in there, they're not going to be as distinct when we stain them. So we break them down into those two groups. So you have 3 cells in the granulocytes, any of the fill cells, neutrophils, basophils, and eosinophils. And then in our agranulocytes, we have our lymphocytes and then our monocytes. Okay, so you can say the sites are in the agranulocytes. So let's talk through this here and just kind of go over some of those specifics. Okay, so visible granules are the granulocytes, right? But the not so much visible granules, and you can see some on agranulocytes if you have a really good light microscope. But that's going to be our way that we classify the two. Not so tough right now? Just you wait. No, I'm just kidding. I'm just kidding. This chapter's not too bad. Not too bad. All right, let's start off with the granulocytes. The first one there, the neutrophils. These are the most numerous. So normally if you have any type of damage to tissue, like if you fall and scrape your knee, it's pretty much going to be neutrophils that are going to be at that site of injury and potential site of infection. So they are the most numerous there. And these are very, very interestingly, I don't want to say shaped cells, but the characteristic of their nucleus is that they have a multi-lobed nucleus. I'll come right back to this slide here. So if you see here on our, and it's not that easy to see on this one. Look at, that's the nucleus right there. This guy, usually a lot of times with a neutrophil, you'll have this irregularly shaped neutrophil, all right, nucleus, right, what we call multi-lobed. So all of that's the nucleus. Very unique. Right, so definitely easy to tell there. All right, we'll still have our granules inside because those granules are going to release these chemicals that will annihilate whatever the pathogen is. And we'll get into detail about that later on. So their job is to go to the spaces where the pathogen is, where the infection is, and they're going to neutralize it. They're going to go in there and kill it by releasing, right, those chemicals that I just told you about onto whatever the pathogen is. All right. So what I tell folks is when you're looking at somebody's blood work and they have an elevated white blood cell count, then you look at what we call the differential. CBC with differential, sometimes folks refer to it as a CBC with diff, when they draw the blood off. And what they're going to do is they're going to look at the blood smear and they're going to see, all right, what's elevated, what's not elevated, what's normal, what's not normal. And so if you have an elevated white blood cell count, then when you look at the differential, we call it, you're looking at which cells, which type of cells are elevated. If you see elevated neutrophils, you should immediately think bacterial infection. It's not always the case 100%, but usually that's what it'll be, okay? Bacterial infection. If you see elevated lymphocytes, then I want you to think viral infection. It's not always the case, but just start to suspect that, and that'll help you with your differential diagnosis. If that's, pardon? Lymphocytes for the virus. All right, the next type are the eosinophils. They don't make up as large of a population of the white blood cells here, and these guys here are also are going to be multi-lobed, technically bilobed, but the interesting fact between those two lobes is that you have this little thin strand. Almost look, well, I'm not going to describe it that way, but you can't really see it as well on this one. Yeah. All right. So you got your two lobes there, and there's this thin strand. It's much more obvious when the lobes are further away from each other, and you'll just see this tiny thin strand connecting those two. It almost kind of looks like this thin strand over here for that neutrophil. All right, but this is not really a great example for that. All right. So these guys, their job is to go around and kind of clean up messes. So if you see an elevated eosinophil count, couple things, but most commonly you want to think some sort of allergen type of response. See it all the time in folks that are asthmatic, right? But also you want to think, this doesn't happen too often, but parasitic worm infection. I mean, that's if like the patient says, hey, I was traveling in Brazil, I was over there for a month, they come back with some sort of infection. You look at their blood draw, and then you see that they have an elevated eosinophil count. Then you would think, all right, probably they picked up some sort of parasitic worm infection. If they've never left the United States, right, then you should start thinking more of an allergic response because they could be elevated there. All right, but what these cells will do is they'll go around and they're like another type of Pac-Man. They'll go around and gobble up, right, antigen antibody, what we call complexes. And that's when you have an antigen and then the antibody gloms onto it, and you can have multiple antigens that are just attaching themselves to this foreign protein or this foreign sugar, which is called an antigen. And so it's just like this big ball of, I don't want to say mush, but it's just this big floating apparatus. And so the eosinophil will come along, look at them like, that's got to go, and just eat it up. That's their job. All right, basophils. And I just got done talking about basophils to my 210 section because there's a cell that's very similar to the basophil. Is it up there? Good, it's not. All right. So basophil lives in the blood, and this other cell lives in tissues. And this cell, it gives us a hard time around allergic reaction time, all right, when allergy season's around. Does anyone know what cell? You may have remembered it from when we did connective tissue. Anybody? You say mast cell? You nailed it. Yeah, it's the mast cell. Yep. So the mast cell is the basophil version in the tissue. Okay, they both carry heparin and histamine. Heparin and histamine. So heparin, right, is an anti-clotting agent. Some people say it's a blood thinner, but it prevents clotting. And the reason why is if there's an injury, you don't want to clot the blood immediately because sometimes you got to get some of that blood to infiltrate the area because what's in the blood? White blood cells, all right? Well, and other types of proteins that we'll need, right, for whatever's going on at that injury site. So we don't want to initially clot the blood. So the basophils will release their heparin. It prevents clotting, and then they'll also release histamine, and histamine causes vasodilation. And when you increase vasodilation, you increase the diameter of the blood vessel, you increase blood flow. We'll talk more about that concept in the circulatory chapter. All right, so that's what the two things that those chemicals do. So we want to increase blood flow because we want to get more supplies there. We want to get more stuff to the site where this potential infection or injury is occurring. And then we want to make sure that we're not clotting. We don't want to, it's like one of you has an injury here and that requires immediate medical attention. None of us can help you, right? EMTs are on their way, and one of you goes and closes the door, all right? Then you can't come in here, all right? We're clotting the room, right? So histamine prevents that from happening, right? We don't want to clot the blood until we can get more of our emergency personnel there. Okay, agranulocytes. We have two, the lymphocytes and the monocytes. So there's different types of lymphocytes, and we'll get into that. We have our T lymphocytes, our B lymphocytes, and then our natural killer cells. But our lymphocytes here, again, most of these leukocytes live in tissues. Well, lymphocytes like to live in tissue named after themselves. Any of the lymphatic organs, lymph nodes, right, spleen, tissues in general, all right, but they're going to hang out in these lymphatic structures, a lot in the lymph nodes, and it's really kind of cool when we get into that, what they do, but keep that in mind. Now, they make up a larger percentage of the leukocytes circulating in your blood than the eosinophils and the basophils. Still, the neutrophils are the most, yeah. No. I won't ask you if that's what you're wondering, but yeah. So I just want you to know that you'll see more lymphocytes in general circulating through the blood. And this cell is very obvious when you see it because the nucleus takes up almost 3/4 of the inside of the cell. That's because these cells make a lot of stuff and the nucleus is active quite a bit. All right, so 3 types. T lymphocytes, again, just for now, just learn what's on the board. We'll get into more details when we get into the later chapters. Immune response. So when there's different types of immune responses that you have, but overall, T lymphocytes are brought in on that. B lymphocytes, right? A good majority of them will convert into plasma cells. Plasma cells make antibodies. And then our natural killer cells, the name tells you everything that it does. Goes around and it kills things. So it'll kill pathogens, and it will actually go around if there's an unhealthy cell, like a cell that's starting to develop cancer. It will go after that cell and kill the cell off. So they're great cells, and it's just an easy description of what they do because they're named after what they do. They go around and kill things. All right, the last one for our agranulocytes. Remember, okay, let's review. Monocyte is in the blood. What do we call that cell when it's in a tissue? Macrophage. Yep, good. Okay, so we saw basophils and mast cells have that relationship depending on what tissue they're in or where they are, I should say, if it's in tissue, it's basophil. If it's in the blood, it is going to be, if it's in the tissue, it's a mast cell. If it's in the blood, it is a basophil. Same thing here. Monocytes, blood. Macrophages, tissue there. Right? And these cells do tons of stuff, but mainly their job is phagocytosis. And y'all remember that. Cell eating. Right? And it's not just for viruses and bacteria or any pathogen. They'll go around and phagocytize damaged tissue like collagen fibers, cell fragments and whatnot. They just go up. They're the cleanup crew. They do so much. So when the monocyte makes its way out of the blood vessel, it goes into the tissue. Then it's now known as a macrophage. And it goes at, and it cleans up all this stuff, bacteria, viruses, and debris, including cellular debris, all sorts of stuff. Protein fibers, collagen, elastic fibers, whatever. In fact, you may have seen the macrophages back in chapter 6 when you learned about the skin healing. You get a cut in the skin. It's at the end of the chapter there. And you get neutrophils and macrophages on hand, on site. And so they both will go after any pathogens that may have gotten into the wound. But the macrophages will start cleaning up the area, and then the fibroblasts come in, they start laying down like collagen and fibrotic tissue to help heal the wound there. Okay, so there's a couple things some terms here that I want you to be familiar with here. So I mentioned to you about the CBC with differential, that blood draw when they look and analyze, all right, what is happening with your white blood cell levels, and then which white blood cells are specifically available here. So a couple terms here. Leukopenia, some of you might be familiar with penia because you may have heard a term like osteopenia. Osteopenia is a reduced bone density. It's not like osteoporosis. That's pathologically reduced bone density. But when we're talking about leukopenia, it's a reduction in something, but it's a reduction in the leukocytes here. So obviously, if you have leukopenia, your white blood cells are diminished, doesn't it make sense that it increases the risk of infection? Yeah, you're more exposed. There's a higher likelihood that you can have an issue there. Then we have leukocytosis, which is the opposite. Now we're going to elevate our leukocyte count. Several causes for this. One could be leukemia, right? Stress will do that, believe it or not, because it's going to stimulate that stress response. But also, maybe you actually have an active infection going on. Something is happening, and so you get an elevated white blood cell count there. So I already told you what the differential count is. This is what tells us what type of cell, how much, all right, and what's going on here. Great tool for determining, right, our differential or our clinical diagnosis there. All right, so then we have, now let's get specific. If you see that term neutrophilia, then think increase in neutrophils. What did I tell you? Neutrophils are usually going to be elevated during bacterial infections. So that's one of the first things that you should be thinking, bacterial infection. But also, okay, stress response. And then I went and told you about what happens to the skin. When you get a cut, you get these white blood cells that are going to infiltrate the area, and neutrophils are usually on hand. And so they're going to be involved, right, when we're talking about tissue necrosis, which is tissue death, right? When damaged cells are done for, these cells come in and start to clean up that area. All right, I'm not really going to worry about the left shifted differential. Neutropenia, again, penia being decreased, right? In this situation here now, if you have a decrease in neutropenia, why do you think anemia or drug or radiation therapies? Well, where are your white blood cells made? Red bone marrow, okay? And usually folks that undergo radiation or chemotherapy, a lot of those drugs will target, all right, the bone marrow. Damage the bone marrow, you damage the factory that makes these cells, therefore you're going to decrease the cell number, right? Anemia, same thing when we're talking about red blood cells, depending on what type of anemia, but normally if we're talking about, like, for example, pernicious anemia, which has to do with red blood cells because you don't have the correct ingredients, but you can have aplastic anemia. Point being is, if you damage the red bone marrow, you're going to damage your bones, well, not your bones, but your body's ability to produce the foreign blood elements. It's going to reduce platelet count, it will reduce your red blood cell count and your white blood cell count. All right, so when we're looking at our monocytes here, different kind of story here when we're talking about monocytes, which is the circulating macrophages. So when you see monocytes increase, we're going to think chronic inflammatory disorders. People with RA, rheumatoid arthritis, any of the arthritides, you'll see it in psoriatic arthritis. We don't see tuberculosis as much as we used to, but again, you'll see elevated monocyte counts with tuberculosis. And if we see a decrease in the monocyte count, this is one of the reasons why we don't like to prescribe steroids long-term. It decreases the immune response because it goes after the monocytes and decreases the cell number. Go ahead.
So how would they determine how
Well, again, like with any type of diagnosis, you got to go with symptoms. So you have to see if the symptoms are present. And usually when they're talking about some of the arthritides, there's going to be an antibody that's present, but it's not always going to be indicative. It's called rheumatoid factor. So they look to see if you're rheumatoid factor positive. Does not necessarily mean you have that condition, but it's likely that you do, because there are sometimes you get the false positives involved there. But usually that's what they're usually looking for. Again, and it involves a lot of things, because you want to look at the history, you want to look at the symptoms of the patient, then obviously the testing. I can usually diagnose RA off an X-ray. I'll take an X-ray of the spine, X-ray of the hands, and you can usually see some pretty common clinical symptoms there. So it's more, I wouldn't really just go off of blood diagnosis to determine if the person has an arthritide. Me personally, okay? Other docs might, but I go for more. I want to be specific, and I want to make sure. Absolutely. All right, basophil. If we see an increase in basophil, right, this we're going to see in myeloproliferative disorders, and those are going to be disorders that affect your bone marrow. Okay, and so again, there's going to be certain, for example, leukemia can affect bone marrow response, and so basophil counts, when you see an increase, that tells us that the bone marrow is going to be producing quite a bit, and we have to question why that is. When we see a decreased amount for basophils, allergic responses and stress. When in doubt, think stress. Stress is a lot in the body. Physical stress, emotional stress, psychological stress. Did I say mental? Mental too. All right. And then we have our lymphocytosis here. Increase in the lymphocytes. What did I say? Always think viral infections. Now, it does say up there also some chronic bacterial infections and leukemias and multiple myelomas. A lot of those affect the bones, which affects the bone marrow. So that's how they found my niece's leukemia. She had her symptoms were more of flu. She was 4 years old. She had ALL, and so she had flu-like symptoms. And then they drew blood, and they're like, "Oh wow, okay, elevated white blood cells. It's probably because of the flu," which happens to more people than you would imagine, right? And so, but it wasn't going away. It wasn't going away. So it wasn't until then that they thought, all right, there's more going on here. And then they started testing for the leukemias there. ALL affects younger people. The CLL affects older people. Okay. Then if we get a decrease in our lymphocytes, you should be thinking conditions or diseases that diminish, right? Specifically, lymphocytes, that's going to be HIV. Other types of leukemia, and then what's sepsis? Yeah, blood infection, just general term for blood infection, but yeah. So, and then I shouldn't say finally, then our eosinophils, if we see those increase, what did I tell you? Always look into allergic reactions, but the history always tells you if they've never traveled outside of the country, right, think allergic reactions. If they have, then I lean more towards the parasitic worm until I'm able to rule that out. And then I think allergic reactions, all right? Okay, so speaking of, all right, leukemia, when we're talking about leukemia, okay, it is a cancer or a malignancy in the leukocyte forming cells. So one of the things we'll see, like I said with my niece, and initially we saw an increase in her white blood cell count. This is why a differential is so important, because when you do that blood smear, you can actually look at the physical characteristics of the cells themselves. Right. And it's been a while since I've gone over pathology, but there's going to be certain characteristics that certain types of leukemia, the lymphocytes will actually display. And if any of you here take a pathology class, you'll learn that. So what we're going to see here with acute leukemia, that's what my niece had. She had acute lymphocytic leukemia. This is the one that affects younger people, so children and young adults. The good news is usually with the acute lymphocytic leukemias, the ALLs, and there's also AML, which is acute myeloid leukemia. Depends on which cell line we're dealing with, right? ALL is the acute lymphocytic. Remember the two cell lines when we're talking about hemopoiesis, hemopoiesis. So anyways, the ALLs are the ones that have a higher, not curability, but a higher survival rate. Okay. See, the chronic, that's the one that affects older people, and that one usually has a higher mortality rate here. But the good thing about chronic is that, if you can say there's a good thing about it, it's slower to progress. So if they catch it early enough, there's a higher likelihood that they can help out the patient there, right? ALL, you got to be on top of things. I shouldn't say ALL, the acute leukemias, because there's different types. All right. And finally, our last blood-formed element, platelets, our platelets. So keep in mind, platelets are not cells. They were once part of a cell. They were once part of that megakaryocyte that one day decided to extend its pro-platelet out into the world, the capillary, and blood just came by and just started breaking pieces of it off. And it's those pieces, those cell fragments, those are the platelets. So keep in mind, because they are cell fragments, no nucleus. Bye-bye. And their job is blood clotting. Don't worry, I won't ask you these numbers, 150,000 to 400,000 per cubic millimeter of blood. Just know there's a lot, all right? It's quite a bit. And those are numbers that they'll look at when they are looking at your CBC with diff to determine if you have elevated platelet count or a decreased platelet count. All right, I always like this number here. It's pretty interesting that a good number of them are stored in the spleen. And that's why when you damage the spleen or if you lose the spleen, right, some folks are concerned about clotting. What's another thing that folks are concerned about if you lose the spleen? Does anyone know? Not so much exercise, but infection, bacterial infection, streptococcal infections. To be really specific, that's the one that folks really are concerned. I had a patient that I found out last weekend was in a car accident. This is the crazy part. In a car accident, you look at the car is obliterated. It's totaled. But they got out of the car and were standing around after the accident. And the paramedics and the emergency staff were like, you really think you should go to the hospital, looking at the car? You know, you really should go. He's, oh, I'm okay, I'm okay. Well, thank God he went, because he had internal bleeding, a ruptured spleen, all this stuff. And the guy's standing around after the accident. I was blown away when his wife was telling me this. Because there's no nucleus, doesn't have any organelles, these structures, these fragments can't really repair themselves. So they have a very short lifespan, 8 to 10 days. 8 to 10, even shorter, much, much shorter than red blood cells, right? What's the lifespan of a red blood cell? 20, good. Right. So again, these don't last that long. So here you can, that's it. All right. We're going to get into more detail about platelets in another chapter. I thought we were going to do it in this chapter, but we're not. Is it in the notes there? But it's not in my notes? What's it say on there? Oh, that's it? Keep going? Oh, okay. Yeah, okay, cool. All right. So this is the last topic for this chapter, which is perfect. And this, if any, pay close attention to everything that I'm going to talk about right now. Okay? You might see it again. That's all I'm saying. All right? Pay close attention to hemostasis. So, first thing about hemostasis, know the definition. Okay? Hemo is blood, stasis is going to be no movement really. So it's blood. If you're bleeding, we're going to stop the bleeding. And there's three parts to it, or three phases. And they're drawn up here nicely. So what I would say is when you're learning about hemostasis, what's this, figure 1812? Learn each of these steps with the writing underneath, just to get the basics. And then we're going to go through it in much more detail. So the first phase is vascular spasm or vasospasm. The next one is we're going to get platelet plug formation. And then the last one here is the coagulation phase. So know those three general phases there. All right, so, and by looking at the names of these phases, you can figure out what's going to happen for the most part. All right, vascular spasm, the blood vessel will go into a spasm. Right? And again, this is going to help decrease blood loss. All right, platelet plug formation, we're going to start to block things up here, right? So we don't bleed or lose more blood. And then finally, we're going to create during the coagulation phase a nice dam, I guess you could say, to make sure that we're not losing any blood. We're going to go into this in more detail here. So let's start off here and talk about, this is the easiest part of the three phases here, is the vascular spasm. So the first thing that you're going to see is what we call vasoconstriction. So what happens with vasoconstriction? Like, what does that mean? When a blood vessel vasoconstricts, what does it do? It gets smaller. Yeah, it gets smaller. So when it gets smaller, would you say it's harder or easier for blood to move through that area? Harder. Good. Good. That's what we want. We want to decrease blood flow. Good. So you're understanding blood flow already. We haven't even gotten to that chapter yet. Right. So that's good. So as long as we know, right, the size of the vessel helps to determine blood flow. Smaller vessels, less blood flow. Larger vessels, more blood flow. Cool? Guys, all right, good. All right. So that's what we're going to see here. So it doesn't last for too long, but it can when I say too long, it depends on how big the vessel is and the extent of the damage there. All right. Obviously, larger leaks or damage to the blood vessel, it'll take longer there. All right. So we want to see, like I just said, greater vasoconstriction with greater vessel damage there. Obviously, it'll take longer. So what we're going to see now is the platelets, and then these cells here. What are endothelial cells? You remember? Endothelium is epithelial tissue, and that epithelial tissue is simple squamous epithelium. That's what we call that simple squamous epithelium that lines the entirety of your blood vessels and your lymphatic vessels. All right, so when you see endothelial cells, just think those are the simple squamous cells that line your blood vessels or your lymphatic vessels there. All right, and so these, and we're going to talk about this, these cells, the platelets and these endothelial cells are going to release these chemicals that are going to contribute to the process of hemostasis, which we're going to talk about here in a few moments. Good so far on the first phase. Vascular spasm, not too bad. Okay, good. All right, let's talk about what happens normally. So I got to paint the picture for you folks right now in all of us. This is exactly what's happening. I'm assuming that everybody is uninjured. So your simple squamous epithelium, your endothelial cells are constantly releasing that chemical up there, prostacyclin. Does that look familiar to you? Maybe not. It's an eicosanoid, a locally acting hormone, okay? But it's releasing this chemical, right? And it literally coats the cell. And it makes it slippery, non-sticky. Because we don't want stuff sticking onto the vessel walls. Why? Has anyone ever heard of atherosclerosis? Plaque. Okay. Plaque is essentially like gum sticking onto the vessel wall. And when you have plaque forming on the vessel wall, it starts to cause the blood to be turbulent. Turbulent blood is no bueno. It's bad because you can damage the cells and you can actually cause, did I tell you guys this? I get my sections confused. You can get blood clot formations. That's bad, especially when we're talking about embolus. Okay, we don't want any of that. So this chemical, this prostacyclin, has one, I should say one job, but one of its functions is to repel platelets, to make sure that the platelets, all right, don't stick onto the side of the blood vessel wall there. Right. So how does it do that? The endothelial cell, so that prostacyclin is going to, you all remember cyclic AMP, right? CAMP. That was in that secondary messenger pathway that you learned about in chapter 17. So anyways, that cyclic AMP is an inhibitor. And so it prevents your platelets from being activated, which is good. In an uninjured person, that's fine. We don't want any of that happening. So this is happening in every single one of us as we're sitting here. So our endothelial cells have coated themselves with the prostacyclin, and that prostacyclin then is going to prevent platelets, one, from attaching onto the vessel wall and from actually starting the clotting process. So all is well, all is good here. All right, so now that was normal. Now what happens? Let's get back to hemostasis. Now we've damaged, all right, that vessel wall. So, as you know, in our blood vessels, hopefully you learned this in 210, you've got different tissues involved. There's in some of the thicker ones, like the arteries, like that's what this picture here is showing you. This is showing you an artery here. So you have 3 layers, and we'll discuss that when we get into the circulatory system. The inner layer is the endothelium. Then usually you'll have a muscular layer there, and then you'll have your 3rd layer on the outer layer there. But you're going to have different tissue in there. Connective tissue, for example. And remember, one of the components of connective tissue are protein fibers, specifically collagen. And I can't remember if there's 8 or 10, there's a whole bunch of different types of collagen in your body. Right? So now that we've damaged the blood vessel wall, now those collagen fibers are exposed. They were once protected, all right, by the endothelium and the other tissue, but now we've damaged that, and so they're exposed. And so what happens is those collagen fibers are going to release this stuff here called von Willebrand factor. And essentially, what did I say about chemotaxis? Remember, it's that chemical attraction to let cells know what's going on? This von Willebrand factor here will let the platelets, hey, something going on over here, so the platelets will float on over. Well, guess what? Since the endothelial cells are damaged, we no longer have to worry about prostacyclin inhibiting the platelets' ability to activate and start the clotting process. Because prostacyclin is out of the picture, because why? The endothelial cell in that area most likely is damaged, right? Because there's exposure of the connective tissue underneath. So we don't have to worry about the prostacyclin repelling, right, our platelets there. So now the platelets can get in on the action, and they'll start to form these long processes. So just kind of extend themselves and start sticking. That's their job, to stick, because in a moment, we're going to create a net, and that net will start catching more stuff. I mean, you can go fishing with just your hands, but you only get 1, maybe 2 fish. Way better to catch more fish with a net. So that's what your body's going to do. It's going to create this net from fibrinogen, which we'll talk about here in a second. All right, so now the platelets are on hand. They're right there. So let's turn them on. All right, so here's what happens. The platelet itself is going to start to release these chemicals. A couple things you want to know. We're all familiar with serotonin, neurotransmitter, but it does more than just neurotransmission, right? Also helps with depression, that sort of thing. So there's a lot of functions for serotonin, right? So the platelets release serotonin and thromboxane A2. Thromboxane A2 is another eicosanoid, right? It's another locally acting hormone. So this will, through the positive feedback mechanism, it will continue to propagate vascular spasm. Vascular spasm will continue to keep vasoconstriction in place so we can reduce blood flow to that area there. So We're all familiar with ATP, adenosine triphosphate. Well, its younger brother or older brother, however you want to look at it, ADP, and again, thromboxane A2 are going to contribute to that chemotaxis type of phenomena, releasing chemicals to attract in more, more platelets with more positive feedback. So again, we're going to be releasing more chemicals, drawing more of our or with our clotting or coagulating products in there, the platelets. All right. So now we're going to be moving here in a second into that third stage there, but we haven't hit it yet. So you can see here, we got our procoagulants that are going to start that coagulation process. And then at the same time, notice how the tissues that are damaged are going to start immediately going into mitosis, start repairing the area there. Right? A lot of those chemicals will influence, right, on your somatic cells, mitosis, that cell division there. All right, so again, we talked about the different penias and tocises there, or cytoses for our other cells. Thrombocytopenia, low platelet count. Again, that could be seen in a couple of different situations and conditions, but anything that affects the red bone marrow will affect your platelet count and and you will have thrombocytopenia there. All right. Last phase. I love this picture. It's just a cool picture with an electron microscope here. You're seeing, right, our clotting going to the next phase where we're going to spread our net. Told you the net was coming. So the final part, the coagulation or blood clotting phase, fibrin comes from fibrinogen that's constantly being produced by your liver right now. So it's on all of us, but when it's called fibrinogen, it's inactivated. So what will happen during the hemostasis process, those chemicals that we just discussed are going to trigger fibrinogen to go through that enzymatic cascade that eventually transforms it and yields fibrin. And so fibrin, you can see, is this, I don't know what that looks like, aqua blue on the picture there. That's that net that allows us to start catching more of our blood-formed elements. In the process, it gets red blood cells because those are really big cells, but they also contribute to the coagulation phase. That's why if you look at a scab, you'll notice that your scab is going to have kind of like reddish, possibly brown coloration to it. And that's because of the red blood cell presence there. But obviously, it's not going to be bright red because those red blood cells weren't oxygenated. That's besides the point. So if you look at this net that we've cast, look at everything that's going to be inside of that, right? You've got red blood cells, more white blood cells, platelets, plasma proteins made from the liver that contribute to the clotting cascade. Now, I think within a slide or two here, maybe on the next slide, there's a picture here. This one right here. You don't have to worry about memorizing it, all right? You have an extrinsic and an intrinsic pathway, and this basically talks about what happens inside the blood vessel, outside the blood vessel. I'm not expecting you to know that part. What I am expecting you to know is this part. Stuff that we need for the clotting cascade. All right, so calcium, clotting factors made by the liver, obviously platelets, but this is the one that I like to draw attention to. Vitamin K, one of our fat-soluble vitamins. This is the one that they tell folks to be careful, all right, with certain types of food consumption. Vitamin K is going to be found in a lot of green leafy vegetables, that sort of thing. If people have clotting disorders, or if they're on blood thinners like Coumadin and heparin, normally they are persuaded or dissuaded, I should say, from consuming foods that are rich in vitamin K, all right, because they don't want these people clotting. So they have to be careful. So when we're looking here at the coagulation phase, most of these clotting factors are inactive enzymes that are going to be produced constantly by the liver, but will only be activated through what I'm going to show you on the next page, this enzymatic cascade process by design, And so again, you'll see these things are called factor 2, factor 5, factor 9, factor 10. And it's only because that's the order that they discovered it in. And some of them have special names. I'm not going to ask you any of that stuff, so you don't have to worry about that, all right? That's for another class, right? But I want you to know that these are made by the liver, and I want you to know that they're usually inactive until an enzyme acts upon them to activate them for the clotting cascade there. And that's what basically will happen. These proteins, these enzymes, which are called proteases, are going to convert that inactive factor into an active factor, which will then move on to the next step of the cascade there. So if you look here on this slide, right, so you have your damaged blood vessel, and so you have these two pathways. The intrinsic is what happens inside the blood vessel, and the extrinsic happens on the outside of the blood vessel. But you'll notice, right, that you'll have these clotting factors being produced, right? For example, our platelets and so forth and so on. And so they'll go through a step-by-step process, both inside the blood vessel, outside the blood vessel, but it all comes down to the bottom part here. It all comes down to fibrin. That's what we're doing. We're trying to make that net. Trying to make that net to catch all that stuff I just mentioned to you. More platelets, more red blood cells, leukocytes. And you'll see this is why, for example, certain ingredients are important. Like, for example, right up here, calcium. Now you've just learned another use for calcium, because you can see it's in a couple of different parts of our clotting pathway. It's over in the extrinsic, it's over in the intrinsic, and then finally in our common pathway at the final point. And so when we're discussing the importance of calcium in our diet, we learned in 210 we need it for bones, right? And we also learned in 210 you need it for muscle contraction. You also need it for nerve cell transmission, for the neurotransmitter. And now you just learned another source for it. You need it for blood clotting. Without calcium or ample amounts of blood clotting, you can't make effective fibrin, and then therefore you can't have an effective clot. So drink your milk. Actually, more importantly, eat broccoli. A cup of milk and a cup of broccoli, which do you think has more calcium in it? Broccoli. Yeah. Right. So eat your vegetables. This is why I tell my kids, you want to bleed out? I don't say that to them. All right. But that's what but I tell them it's important. Right? Eat your vegetables. You don't want your eyes to start bleeding. No, I'm kidding. I would never say that to them. All right. So you can kind of see, again, I don't expect you to know all the different steps, but I want you to be familiar with it. Just be familiar with it. All right. And so the last part here, pay close attention to this. All right. So what happens when you start to lose, all right, 10% of your blood? Might not seem like a lot, right? But if it's 10% or more, now we're going to involve the sympathetic nervous system. And things are really going to kind of, I don't want to say kick into high gear, but sympathetic nervous system, fight or flight. And usually what happens when you get sympathetic nervous system stimulation? Breathing rate increases, heart rate increases, right? Blood pressure will go up, right? So we'll see all those things. But also, and I hope y'all learn this, and I'm going to assume that you did, the sympathetic nervous system is the only division or the only branch of the autonomic nervous system that affects your blood vessel size. I hope you all know that, okay? It's not one of those things where you have the antagonistic relationship between parasympathetic and sympathetic, because working on an organ or a tissue. Sympathetic does vasoconstriction, and then when you turn off the sympathetic, it just the cells or the blood vessel relaxes and it returns to its original size. So you get vasodilation. So what we're going to see is when the sympathetic nervous system gets turned on, we're going to see a significant increase in vasoconstriction. So vasoconstriction occurs, and as you know, it increases resistance, which therefore decreases blood flow. Good, because we've now stemmed some of that blood loss there because we're decreasing the blood flow to the area. But now keep in mind, when it's a significant amount, say it's really big, but let's say you've lost 30% of your blood. Tissues still need blood. They still have oxygen demand. So what's going to happen? Because those tissues need that oxygen, your heart rate's going to increase, right? And your blood pressure is going to increase because we need to get blood to those other tissues. Even though you're bleeding in your arm, or say you chopped your hand off and you're bleeding out there, right? Your feet still need blood. Your liver still needs blood. Your brain obviously definitely needs blood. So we have to maintain or increase blood flow to those areas as we're losing blood in other areas there. So that's where the sympathetic nervous system comes in. We've got to take care of the really important organs and tissues, and that would be obviously your brain, but the heart and some of the other tissues there. So again, this whole process is just based on trying to maintain that normal blood pressure. So whatever your normal blood pressure would be, it's 120 over 80, right? We want to maintain that everywhere. But once we get past this number, 40%, then it's no longer really sustainable. It's definitely not sustainable for a long period of time. You've only got moments, okay, before something really bad happens. All right. So that's the end of chapter 18, which means